Good morning. We're going to get started. So I'm really, really pleased today to have the opportunity to introduce both of our speakers. And these are both the awardees of the Trainee Research Awards. So, and it's my particular pleasure because both of these are my mentees. So our first speaker is Dr. Clémence Cavaillès. She is a postdoctoral researcher with us at the Center for Population Brain Health, and she's been with us for about 2 years. Been remarkably productive, as you can see by her talk. Before she came to the U.S., she received her PhD in France from the Institute of Neuroscience at Montpellier. She's been very interested in the connections between sleep and cognitive aging, and as you'll see, the bidirectional relationship in particular, and those at special high risk. So she's going to talk to us based on some of her work. As I said, she's been really remarkably productive in just 2 years, and we're very, very pleased to hear her talk about sleep and cognitive aging, an epidemiologic approach. Clémence.
Good morning, everyone. Thank you, Christine, for this kind of introduction. And I also want to thank the department for this award. I'm very grateful. So first, before starting, just a bit more about my journey. So I started with an undergraduate degree in mathematics, but it was too theoretical for me. So that led me to a master's degree in epidemiology, where I could apply my mathematical skills to medicine and population health. And during an internship, I became fascinated by sleep research. So this led me, as Christine said, to a PhD in sleep and dementia. And from the start of my PhD, I was already reading Christine's work, and I was inspired by the novelty of their studies, their amazing data, and also their expertise in cognition. And so by the end of my PhD, I knew I wanted to continue investigating sleep and cognition. So I sent an email to Christine, and here I am at UCSF. So let's talk about some of my research that I realized during my postdoc on sleep and cognitive aging with an epidemiological approach. So dementia is a very common syndrome affecting over 15 million people worldwide in 2019. And this number is expected to more than double by 2050. So this rising prevalence is a major concern, especially with an aging population. And interestingly, aging also brings significant changes in sleep. So older adults take more time to fall asleep. They have more nighttime awakenings, more daytime sleepiness, and they have more higher prevalence of sleep disorders. But they also have a shorter sleep duration, less deep sleep, and an overall poor sleep quality. So understanding the link between sleep and dementia is therefore crucial, as sleep may serve as a potential modifiable risk factor for dementia in the absence of a cure. So sleep has attracted growing interest in the context of dementia. We already know that dementia increases the risk of poor sleep. Indeed, 50% of dementia patients have sleep disturbances, and this may be due to lifestyle changes, medication, and brain alterations. However, it remains unclear whether poor sleep increases the risk of dementia. So in the literature, several sleep disorders such as sleep apnea and insomnia have been associated with poor cognition and a higher risk of developing Alzheimer's disease and related dementias. And it's also the case for specific sleep characteristics, such as sleep duration, where you can see on this plot, short sleep duration, and both short and long sleep duration were associated with a higher risk of Alzheimer's disease. However, conflicting findings persist. So as I said, some studies indicated a U-shaped relationship between sleep duration and dementia. However, other studies found only an association for short or for long sleep duration, or no association. Similarly, napping was associated with a higher risk of dementia, but other studies found no association or even sometimes a lower risk. And another example is sleep timing, where sometimes we find an association with an earlier and sometimes a later rhythm and dementia. So these conflicting findings may be due in part to two main limitations. So first, most studies focus on one sleep parameter at a time, and mainly sleep duration. And so this, there is a lack of consideration of the multidimensional nature of sleep. Sleep can be actually measured across multiple dimensions, and therefore looking at only one parameter may not reflect someone's sleep pattern. And also, most studies have a cross-sectional design, and they focus on older population. And this raises concern about about reverse causality. So when the disease actually causes the exposure. So in other words, does poor sleep increase the risk of dementia, or is it a consequence of dementia? So in this presentation, we're going to focus on these two main limitations and see what we did to try to overcome them. So first, let's talk about the multidimensional aspects of sleep. So sleep can be measured, as I said, across multiple dimensions, such as sleep duration, sleep regularity, sleep timing, quality, efficiency, and daytime sleepiness. And so you can have a good level on one dimension and a poor level in another one at the same time. So for example, I can have a good sleep duration according to the current recommendation, and at the same time not satisfied by my overall sleep. So studying the overall sleep profile may be a more comprehensive assessment of sleep and a more realistic approach that can help yield novel insights. So this led us to this first study published in the Journal of Alzheimer's Disease, where we looked at the longitudinal association between a multidimensional sleep health measure and cognitive decline. So for that, we used data from the Mr. Oz study, which is a a multi-center study, with community dwelling men aged 65 years old and over. So the participants were followed for about 12 years, and they had 5 assessments of their cognitive function over the follow-up. And we looked at their self-reported sleep at baseline. So we investigated 5 sleep dimensions: satisfaction, alertness, timing, efficiency, and duration. And we categorize them as good or poor. And here you can see the prevalence of the poor sleep health dimension. And so then we used 2 cognitive tests. So the 3MS score for global cognition and the TRACE-B completion time for executive function. And so lower 3MS score and higher TRACE-B completion time are associated with worse cognition. And so over 10 years, we found that the 3MS score decreased by 3.9 points, and the TRACE-B completion time increases by 40.8 seconds for those with at least one poor sleep health dimension compared to those with none. Moreover, we further categorized the number of poor sleep health dimension in 3 categories to see if there is a potential dose-response relationship. And we found was with TRACE-B completion time. So the TRACE-B time increased for those with 1 to 2 poor sleep health dimension compared to those with none, and even more for those with 3 to 5 poor sleep health dimension. And so here you can see the dimensions and analyzed separately, and you can see that only poor latency was associated with 3MS score, and only poor timing was associated with TRACE-B completion time. So in summary, in this study, we show that multidimensional measure of sleep health was associated with long-term decline in both global cognition and executive function. And we also showed that considering individual sleep health dimensions separately may underestimate the effect of sleep on cognition. And so strong by these findings, we wanted to go further and to look at objective sleep measures and also to identify common sleep profiles. So in this study, this is what we did in this study, where we aim to identify actigraphy-derived 24-hour sleep and circadian profiles, and then to determine whether these profiles were associated with the incidence of dementia. So again, we use data from the Mr. Oz study. The participants were still followed for about 12 years with an active screening for the incidence of dementia over the follow-up. And this time, we use actigraphy measure at baseline. So the participant had to wear sleep watch or actigraph for at least 4 consecutive 24-hour periods. And so in here, you can see just to show you all the variables that we use to identify the clusters, and the fact that we use both nighttime and daytime sleep variables and circadian rhythm variable, which is really rare in the literature. And you can see that we identify 3 profiles. And what is interesting to see is that all the sleep variables were highly significantly different between the 3 groups. So overall, we found one group of active healthy sleepers with high sleep efficiency, strong circadian rhythmicity, and high activity during wake periods. A group of fragmented poor sleepers with short sleep duration, long time in bed, low sleep efficiency, high sleep fragmentation, and weak circadian rhythmicity. And a group of nappers with frequent and longer naps and good sleep efficiency. And so over the follow-up, we observed 461 incident dementia cases. And so compared to the active healthy sleepers in green, we found that the fragmented poor sleepers had an increased risk of developing dementia. However, we found no association with the nappers group. So in summary, we found that poor sleep with disrupted circadian rhythm could be a risk factor or preclinical marker of dementia. So from the nappers group, we are showing that long and frequent napping, when combined with good nighttime sleep dimension, this might not affect the risk of dementia. And I think this is very interesting because usually in the literature and also in our sample, we found that longer and more frequent naps analyzed separately were associated with a higher risk of dementia. So maybe there is a compensation process between daytime and nighttime sleep parameters. So with this study, we showed again the importance of considering a combination of sleep and circadian dimension, and we also identified potential target population for sleep intervention. So now let's talk about this question: is sleep a consequence or risk factor for dementia? So a bit of spoiler, there is no good answer, but let's see what we did to overcome the reverse causality problem. So one way of doing that is to look at younger population before any physiopathological changes related to dementia. So this is what we did in this study published in Neurology, where we looked at the association between sleep in midlife and neuroimaging marker of brain age. We use data from the cardiac studies. The participants were aged about 40 years old at baseline on average. And we looked at self-reported sleep at baseline. Then the participants were followed for about 15 years and they had a brain MRI. And then we used the machine learning to derive brain age compared to chronological age by quantifying individual differences in age-related atrophy. And so older brain age is associated with worse cognitive function and Alzheimer's disease-related atrophy patterns. So here are the results. We looked at sleep duration, sleep quality, 3 insomnia symptoms, and daytime sleepiness. And then we also created a composite score, again, looking at the multidimensionality of sleep. And we found a dose-response relationship between an increased number of post-sleep characteristics and older brain age. So more specifically, we found that the participant with 2 to 3 post-sleep characteristics, they had a brain age 1.6 years older than those with no more than 1 post-sleep health characteristics. And those with more than 3 had a brain age 2.6 years older. And when you look at the parameters individually, you can see that only early morning awakening was associated with brain age. Though these results show that poor sleep in midlife is associated with accelerated brain aging. And here, so these are preliminary results, but in the same study, we looked at the same sleep parameters, and this time we looked at Alzheimer's disease biomarkers 20 years later. And we found that poor sleep quality and daytime sleepiness were associated with higher levels of neurofilament light chain, and also that daytime sleepiness was associated with lower level of beta amyloid 42/40 ratio, which are both associated with an increased risk of Alzheimer's disease. So I think that these results are really amazing, and they show that poor sleep 20 years prior is associated with Alzheimer's disease biomarkers. And so taken together, these results show that poor sleep may have effects on brain health as early as midlife. And so in this last study, we aim to explore this time the causal link between sleep and dementia, and especially sleep apnea. So sleep apnea has been linked to a higher risk of dementia, but the mechanism remain unclear. So two main pathways are hypothesized: that sleep apnea may promote Alzheimer's disease protein accumulation, and also that sleep apnea may increase the risk of cardiovascular disease that are a well-known risk factor for dementia. However, these studies face limitations, such as residual confounding and reverse causality. And so we used an approach that combined epidemiology and genetic that allow to look at the direction of the association. So this method overcomes this limitation by using genetic variants. And so this method is called the Mendelian randomization. So for this study, we looked at Alzheimer's disease for the neurodegenerative pathway and two cardiovascular diseases for the cerebrovascular pathway, for stroke and coronary artery disease. And we found that genetically predicted sleep apnea did not increase the risk of Alzheimer's disease. However, it increased the risk of stroke and coronary artery disease. And also with some sensitivity analysis, we found that the association with stroke was in part driven by BMI. And also because we are looking at the bidirectional association, we looked at this association in the other way. And we found that genetically predicted Alzheimer's disease, stroke, and coronary artery disease did not increase the risk of sleep apnea. So these findings suggest that the cerebrovascular pathology may play a more important role than the Alzheimer's disease pathology in the sleep apnea dementia association. So in summary, in this presentation, we showed that the sleep is increasingly recognized as both a potential marker and a risk factor for dementia. And we notably showed that sleep could affect brain health as early as midlife. We showed the importance of studying a combination of sleep dimension, as well as the importance of the cerebrovascular pathology in the sleep apnea dementia association. And we identified a potential target population for sleep interventions. And so in the other part of my postdoc, I wanted to tackle another main limitation, which is the lack of diversity, because indeed most studies are made in mainly white population, and there are insufficient studies on sex disparities. And so now I'm using a new diverse cohort led by Christine called the Dormier study. So just briefly, Dormier is a sleep study ancillary to the HAP study, which is an ongoing community-based study on cognitive aging among Black, Mexican, American, and non-Hispanic white participants. And so the Dormier participants received a comprehensive assessment of their subjective and objective sleep. So the study included 1,002 participants. There were 66 years old, 65% are women, and 25% have a cognitive impairment. And so on the right side, you can see some preliminary results showing that the non-white participants exhibited significantly worse sleep than the non-Hispanic white participants, with notably a shorter sleep duration, poor sleep efficiency, and higher sleep fragmentation. So now a bit about my next steps. So first, I'm going to continue investigating disparities in sleep across socio-demographic groups, and also to explore their relationship with cognitive health. And then, so it's actually my last day today at Pritzker. And so I'm going back to France, to Paris, for a new postdoc position with the goal of a faculty position. And so in this next phase, I plan to develop a predictive tool for dementia risk using sleep data. And I also want to investigate the life course approach with notably the sleep trajectories and their joint evolution with cognitive function. So I want to thank my amazing mentor, Christine, all my colleagues at the Center for Population Brain Health Lab, all my co-author, and also thanks to you for your attention.
Fantastic presentation. Thank you so much. I'm a geriatric psychiatrist, and I want to tell you your paper made a great impact. Actually, one of my patients sent it to me, the one that looked at the midlife association of sleep disturbances with risk of dementia. So I have two questions, and for the first one, I apologize, I missed the first 5 minutes. Did you control for benzodiazepines or sleep aids in the looking at the risk of dementia study? So that's the first one.
Yes, thank you so much. I'm really happy to hear that, first of all. And yes, we took into account the sleep medication. Yes.
Perfect. Thank you so much. And then the other question is, I think in geriatric psychiatry, we're starting to understand more and more that neuropsychiatric symptoms are correlating with biomarkers, which you beautifully showed with the sleep disturbances, but also things like anxiety and depression, and then they may actually increase the risk of conversion from a prodromal state to the clinical, more overt state. So the question is, do you think that these symptoms, sleep disturbances, could be symptoms of anxiety or depressive disorders, and then maybe kind of factor that in? Thanks so much.
Yeah, thank you. Yeah, it's very interesting. Actually, it's a tricky question. I think taking into account depression, in the relationship between sleep and dementia, it's always complicated. And I think the relationship between sleep and depression is also complicated, because I think it's also a bidirectional relationship. At the same time, if you have sleep disorder, you have more risk of having depression or anxiety, and it's also the other way around. So I think, yeah, there is probably, I think we should do more about this and study maybe all of the three of them together. And probably, yeah, there is a additive effect. And this is why I think in all our study, we try to adjust for depression, anxiety, or at least see if there is an interaction or something, but yeah.
Hi, is there any research showing if you improve your sleep that it helps to kind of help improve like either like the severity of the dementia or anything like that?
So right now it's a bit, there are some studies, but for now I think the results are very preliminary. The effects is always on because it's very difficult to look at the effect of a change on sleep on dementia. So I think on cognition, the effects for now, what we have seen are more a change for a few days, like a better memory or something like that in the few days. But for now, we don't have, from what I know, we don't know about the dementia severity or something like this. We don't know yet.
Hello?
Thank you.
Oh, well, next time. Am I unmute? Hold on. Yes.
Go ahead. Question?
Oh,
That's your question.
can you hear me?
Yes.
Oh, hey, this is Andy Tompkins from ZSFG. I'm an addiction psychiatrist, and of course, a lot of illicit and licit substances can cause sleep disturbances, as well as be associated with dementia. And so I wondered if any of the people in any of the cohorts had a history or current use of alcohol, opioids, even for chronic pain or stimulants?
It is possible, yes. most of the time, as I said, we adjusted for the sleep medication. Sometimes we also looked at the alcohol consumption when possible. And for the chronic pain, I think, yes, it is possible that some of them have this, and we can take into account this aspect too. Thank you.